Welcome to Pathology Central Key Concepts. The topic of this video is chronic inflammation and tissue repair. This will intersect nicely with the videos on acute inflammation and on patterns of acute inflammation. But let's focus on the topic at hand. In this video, I will be reviewing the key features of chronic inflammation, the process of tissue repair, and we'll finish up by discussing the factors that impede healing. So what is chronic inflammation? We're talking here about a response of a prolonged duration, so weeks to months. And there can be variable components of inflammation, tissue injury, and attempts at repair. Now, as you'll recall from the acute inflammation video in which I discussed the outcomes of acute inflammation, chronic inflammation may develop from acute inflammation. On the other hand, it can also arise de novo. It may coexist with acute inflammation, and that's something important to recognize, is that we talk about these different categories, acute inflammation, chronic inflammation, granulomatous inflammation, as if they are distinct, but there is almost always some overlap and coexistence among them. Now, when we think of chronic inflammation, there are three things that we think about as far as the causes of chronic inflammation. One is persistent infection by difficult to eradicate organisms. Classic example is Mycobacterium tuberculosis, but also can be fungi as well as some other viruses, for example. We also can get chronic inflammation in the setting of hypersensitivity diseases, so allergies or autoimmune diseases. And finally, we can see chronic inflammation when we have prolonged exposure to potentially toxic agents, such as silica and cholesterol. Now, cholesterol will be in the context of atherosclerosis. And as you'll recall, atherosclerosis is an inflammatory state, and that is part of what the challenge is of atherosclerosis. So morphologically, we'll see mixed inflammation in chronic inflammation. Macrophages, lymphocytes, plasma cells, eosinophils, mast cells, cast of thousands. So pretty much any type of cell can show up in chronic inflammation. And in fact, neutrophils can be there, either because there's some sort of persistent microbes. So if we're looking perhaps at an ulcer, we have continued exposure and colonization by microbes. Or it can be recruitment by cytokines, because when you have this cast of thousands, they're putting out all of these inflammatory mediators, and the curious neutrophil is going to come on over to check out and see what's going on. Now, another important morphologic manifestation of chronic inflammation is granulomatous inflammation. More on that later. Now let's begin by talking about an ulcer. You saw this image in the video on patterns of acute inflammation. So here we see the ulcer. This is a serous crust with dead and dying neutrophils. And here is the adjacent tissue where we have chronic inflammation. And you can recognize it first by this fibrosis, which is a typical response to chronic inflammation, as well as these sheets of lymphocytes. Now, how do you know they're lymphocytes? We'll look on higher power. First, let's take a look at the interface between the serous crust with the disintegrating neutrophils. Here's that little tongue of squamous epithelium, and here is the chronic inflammation that is subjacent. And you can see here a couple of important factors. We have some dilated blood vessels, which we associate with inflammation. There's some edema, which we can recognize by these clear spaces. And then we have these collections of lymphocytes. And we can't tell looking at these, are these B cells, are these T cells? Don't really see any plasma cells. And for me, as a bone pathologist, I'm always on the lookout for plasma cells, because that's what you need to diagnose chronic osteomyelitis. So whenever I'm thinking chronic inflammation, I'm looking for plasma cells. And I looked around and I didn't really see any. Let's look at this deeper area of that same specimen, and you can see here these sheets of lymphocytes. Admixed now, you can see some eosinophils percolating through. So why don't I see any plasma cells? Now, it all has to do with what the immune system is responding to. And we have something which is interesting here. We don't typically do this, but these immunohistochemical stains were performed on the specimen. And you can see that most of these small lymphocytes are CD3 positive, and that is going to be for T cells, so CD4 positive and CD8 positive T cells. So most of the cells we're seeing in the small lymphocytes are T cells, with only a small scattering of mature B cells, which are positive for CD20. So no wonder I couldn't find any plasma cells. Now, here we have an example that I also show in the acute inflammation video. And one of the reasons here is again to highlight that we can get acute and chronic and even granulomatous inflammation in the same location. So this is a splinter recognized here by some vegetable matter. Here is the overlying skin. Here is an abscess that's been formed. This is going to be that sea of pus, which is going to be dead, dying, and viable neutrophils, as well as edema fluid and necrotic cells. And then we have some fibrosis around the edge, and there'll be chronic inflammation through here as well. And that, in fact, is going to take us to my favorite cell, which is the plasma cell. So you can see here some beautiful examples. This one looks to me like a little ladybug with the eccentric nucleus and the little perinuclear Hoff, because that's where the antibodies are coming from. We can also appreciate the fibrosis, which we will see in chronic inflammation. And then we have some macrophages. You can recognize them here by the somewhat foamy appearance of their cytoplasm. All right, so this brings us now to the topic of granulomatous inflammation, because as you may recall from the acute inflammation video, there are a few multinucleated giant cells associated with that splinter because it's a foreign body. So what is granulomatous inflammation? Well, it is a pattern of chronic inflammation that's characterized by activated macrophages, which we refer to as epithelioid cells. We call them this because they have abundant cytoplasm, so they look like epithelial cells, so they're epithelioid. Now, these macrophages can form multinucleated giant cells, and the granuloma itself may or may not have central necrosis, which can be a clue when we're thinking about etiology. And what granulomas are is an attempt by the cell to contain a difficult to eradicate agent. So it may be a foreign body, or it could be a difficult to eradicate microbe. Now, there are two types of granulomas. There are immune granulomas and foreign body granulomas, and we're going to go through each of these in loving detail. Let us begin with immune granulomas. So this is going to be an ongoing T-cell mediated response to a persistent microbe, such as Mycobacterium tuberculosis, or self-antigen. Why self-antigen? Well, self-antigen is going to be persistent because you're made up of self-antigen. And so if you are having an autoimmune response, then your cells are constantly looking and seeing self and having an immune response. And what happens in immune granulomas is that macrophages are going to activate T cells, and those T cells are going to secrete cytokines. And those cytokines, such as IL-2, are going to activate more T cells, or interferon gamma, activate macrophages. So you have this self-perpetuating cycle. Now, one thing to always keep in mind when we talk about inflammation is that what these cells are doing is elaborating inflammatory mediators, and this is going to activate T cells, other cells around. T cell activation can cause collateral damage to adjacent tissue. Now, here is a nice figure from Pathologic Basis of Disease, a nice little cartoon, where you can see the antigen-presenting cell is holding out something to the CD4 positive Th1 cell. It's going to then elaborate some cytokines, which is going to drag these leukocytes out of the vasculature into the tissue, where these monocytes, under the influence of interferon gamma, will become activated macrophages. These activated macrophages are going to feed back to that CD4 positive T cell, sending some IL-12, and is also going to present antigen to cells. And what we're going to end up with here is this beautiful cartoon of a granuloma with our activated macrophages, our epithelioid cells, and our multinucleated giant cells. Well, that's a cartoon. Let's look at the real thing. So here you can see an image which should be familiar to you because this is the one that I use for caseous necrosis in the different types of necrosis video. So what you see here is the caseous necrosis. This is a case of tuberculosis. And what's happening is the immune system isn't able to eradicate that organism, so it's trying to wall it off. So we see fibrosis here, and we have our multinucleated giant cells here at the periphery. Now, I want to show you another example. This too is tuberculosis. We don't have the multinucleated giant cells, but these are those epithelioid macrophages. And when you look at them, you'll notice that they don't seem to have strong cell borders or distinct cell borders. They have this syncytial appearance. And then you have this caseous necrosis in the middle. Now, this is an immune granuloma, and you can see something that looks almost exactly like this in rheumatoid arthritis, a rheumatoid nodule. So you'll see these patterns again and again, and they will give you some clues about the etiology and the disease process. I can't finish up without another classic example of tuberculosis granuloma. Here we have our beautiful multinucleated giant cells and our caseous necrosis. So now let's move on to the other type of granulomas, which is foreign body granulomas. And we see this when we have some sort of relatively inert, which is to say non-immunogenic foreign body. So this can be talc, which can be in cocaine that is insufflated. It may be sutures that have been put in as part of a surgical procedure. And because they're non-immunogenic, we don't see this T cell response. What is happening is whenever the body has something that is non-self within it, it tries to wall that off. And so that's what we're seeing in this case. And again, I'm bringing back that image of the splinter. This is showing the abscess cavity with dead, dying neutrophils. And here are some multinucleated giant cells. These are macrophages that are trying to consume this gigantic piece of wood. They will be ultimately destined to fail, unfortunately. Much as these multinucleated giant cells, look at this gigantic one here with perhaps 50 to 75 nuclei. And you can see a little bit of refractile suture material within this one giant multinucleated giant cell. And then here is that suture material again, and these are the macrophages that are trying to digest it. It almost looks like they're opening their mouths wide to engulf it. We also see some macrophages here that have not become multinucleated. We have some fibrosis surrounding, but minimal inflammation. So that brings us to the end of what I would call our chronic inflammation portion of this video. I'm going to spend the rest of this time focusing on tissue repair and healing. We've talked about acute inflammation, we've talked about chronic inflammation. Now let's talk about how the body is going to actually repair the injuries that have happened to it. So the goal is to restore tissue architecture and function after injury. And there are two processes that the body can use. One is regeneration, in which you have restoration of normal cells and you return back to your healthy state. The other is scarring or fibrosis, in which the body is not able to completely return to normal health and has to deal with the deficit by putting in connective tissue. So regeneration is something that we can see when we have a mild or superficial injury. Here you can see the basement membrane is intact. This is something that you would see maybe with a scrape or a shallow cut. The body is going to have these cells are going to proliferate. We'll get regeneration. You know, a month after you've had a small cut, you can't even find where that was anymore. Now, if you have a severe injury, where perhaps a chunk of tissue is removed, the body is no longer able to simply fill that in. So what we have to do is form a scar where we have this collagen, which is going to fill in that area. So let's go into this in more detail. First, let's look at regeneration. So regeneration is going to be driven by growth factors because we're going to have cellular proliferation. It requires the integrity of the extracellular matrix, and without this, we're not able to have the scaffolding for which regeneration can occur successfully. What happens is, in the context of this inflammation, we have activated macrophages as well as epithelial and stromal cells that secrete mediators, which are going to drive the proliferation of the residual cells as well as development of mature cells from stem cells, which can either be in the tissue or maybe circulating. Now, in tissues that have rapidly proliferating cells, for example, the surface epithelia, so a shallow ulcer in the stomach or a cut on the skin, the cells are already able to proliferate rapidly. This will happen very smoothly, no problem at all. Now, most tissues are not rapidly proliferating all the time, and these are in a quiescent state. They're in the G0 phase of the cell cycle, but they can be driven to proliferate by these mediators. And examples of these quiescent tissues and cells are smooth muscle cells, fibroblasts, and solid organs, endothelial cells, etc. And endothelial cells, smooth muscle cells, and fibroblasts are critical for wound healing. Now, of course, there are parts of our body that really don't proliferate. So cardiac myocytes don't, most neurons don't. And in that case, you will not be able to regenerate. You will have to scar. Now, another thing to point out is that we can only get restoration of the normal architecture if the tissue architecture is structurally intact. So, for example, if there is an acute hepatitis and that then resolves, there's injury to scattered hepatocytes, but once that injury is removed, once the stimulus is removed, the hepatocytes can regenerate and you will have no idea that anything ever happened to that liver. But if you have a big deficit, so say you get a hepatic abscess, even once that is cleared, now we've lost that tissue architecture and we're still going to have a scar. That brings me to one other issue, is that scar is what we use generally when we refer to epithelia. We refer to fibrosis when we see it in parenchymal organs, such as the liver or in the lungs, although the terms can be used interchangeably. Okay. Back to our regularly scheduled program with repair by scarring. So this is what we do when the regenerative repair is incomplete. We're not able to return to normal function. We can't completely fill in the gap. And in this case, those injured cells will be replaced by connective tissue, leading to a scar. Now, there are 3 phases to this. The first is inflammation, in which we get clearance of the offending agent and removal of debris. And this begins about 6 to 48 hours after the initial insult. It'll go on for a while, depending on how long it takes to remove debris. Remember, the macrophages are only showing up after 48 hours themselves. We're then going to be, the next phase is going to be cell proliferation and deposition of connective tissue. And this can go on for up to 10 days. We also then will get remodeling over months to years. So a scar that you have a month from now, a year later is going to look very different. So we'll talk about that in a moment. And these are those 3 phases. This is a figure from Robbins Kumar Basic Pathology 11th edition, showing inflammation, proliferation, and extracellular matrix deposition, and then the final collagen scar. So let's talk now about those phases in a little bit more detail. So in the inflammatory phase, we have both M1 and M2 macrophages. And you may be thinking, M1, M2, did I see that in the book? I'll show you in the next slide. So the M1 macrophages are the more inflammatory macrophages, and they're going to be doing the phagocytic job of clearing necrotic tissue. M2 macrophages are the healing portion, or the healing subset of macrophages. They'll be producing growth factors that are going to drive us towards healing and repair. In the next phase, cellular proliferation and connective tissue deposition, we're going to have proliferation of a variety of different cells, so epithelial cells, endothelial cells, and fibroblasts. And I've listed the factors that are involved: VEGF, PDGF, transforming growth factor beta, fibroblast growth factor. And when we talk about endothelial cell proliferation, we're also talking, very importantly, about angiogenesis. So if you are filling in a large defect, you have to get a blood supply to it. And so VEGF is going to help us to build new vessels to supply that tissue. And what this mass of proliferating tissue and connective tissue deposition looks like is this raw granular tissue, and it's referred to as granulation tissue. And we'll talk about that, and I'll show you an image in a little bit. And then finally, we have to have remodeling. And so this is going to be largely due to a balance between matrix metalloproteinases, which will be degrading some of the tissue, and tissue inhibitors of matrix metalloproteinases, which will be inhibiting our matrix metalloproteinases. So now let's look at each of these in detail, beginning with inflammation. So as I mentioned, M1 macrophages are going to clear necrotic tissue. M2 macrophages are going to do with wound repair, not wound repair, wound repair and fibrosis. So this is just to remind you that what we see in macrophages is that they can differentiate along 2 different pathways. One is the M1, the classically activated macrophage, which is involved in phagocytosis and killing of bacteria and fungi. So this really drives inflammation. And then the alternatively activated macrophage, which has anti-inflammatory effects and wound repair and fibrosis. So let's now take a look at that second phase, the cell proliferation and collagen deposition area. This is a micrograph showing granulation tissue. You'll notice immediately how filled with blood vessels this is. So this is really got a lot of vascular proliferation to nourish the tissue. And it's very loose. It's got some myxoid gelatinous stroma and not much inflammation. So this is this tissue that is filling in beneath that clot. And you can see here, or scab, and what you can see here is these epithelial cells are going to grow in across that granulation tissue. Now, if you've ever had a scab, like a thick scab, and it's starting to heal, and you notice it sort of loosens on the side, and then you get impatient and you pluck it off, and there's that little area beneath which is sort of pink and bleeds easily. There you're looking at your very own granulation tissue. Okay, so the final step is going to be remodeling, because when the body has an injury, similar to when you have a broken bone, the body's first action is to stabilize it, and then we'll work on remodeling the bone so it can support us. When you have an injury, a tissue injury, and you need to fill it in, the body's like, whoa, let's just throw in some spackle and get it solid so that we're not exposed to the elements. Once you've done that, now it's time to start making that particular scaffolding strong and making it less prominent, so decreasing it in size. So to increase strength, we're going to cross-link our collagen, we're going to increase the size of our collagen fibers, and we're going to shift from type 3 collagen to type 1 collagen, which is more durable. The next thing we have to do is decrease the size. And so this is going to be the action of matrix metalloproteinases, which are produced by fibroblasts, macrophages, neutrophils, and regulated by growth factors and cytokines. And some matrix metalloproteinases are collagenases and gelatinases, as well as something called a stromolysin. And as I said, it's going to be a balance between the TIMPs and the MMPs that's going to drive us in the correct direction. So let's finish by taking a look at the scar. Here is a section of a collagenous scar. You may be wondering why it's bright blue. That's because this is stained with a trichrome stain, which stains collagen blue. So clearly this is all collagen. So an important thing to recognize, so here we have the skin that had that big defect in it. We have collagen scar here. Now there may very well have been a hair follicle here. When the body is repairing this injury, it's not worried about, oh, let's have a hair here. It's let's fill this in. So we're not going to actually have a return to our normal tissue again. It's going to have collagen here instead. And if you were to biopsy this or see an excision from a surgical site, you'll notice that a lot of the adnexal structures are missing because the body does not replace those. So just to finish up, here is our progression from inflammation to our granulation tissue here, and finally our collagenous scar. Now I'm going to go through the factors that impair healing because they're very important for you as future physicians, because it's not simply a matter of getting a cut and getting stitches and it heals very quickly and you go on about your business, because many of the patients you'll be seeing will be having additional comorbidities or challenges. So we need to be aware that there are certain factors that impair healing. So for example, a superimposed infection is going to impair healing because it prolongs inflammation. Inflammation is going to bring in those inflammatory mediators. There'll be some collateral tissue damage, so that's going to slow that down. Diabetes is a particular systemic disease which is important in impaired healing, because not only do we have the decreased blood flow due to peripheral vascular disease, but hyperglycemia will impair leukocyte function. Poor nutritional status is going to impair healing, so protein malnutrition, and then vitamin C deficiency because it's necessary for forming the collagen cross-linking. Glucocorticoids will inhibit TGF-beta production and thereby diminish fibrosis, contributing to weakness of the wound repair. And mechanical factors. So when you're doing your surgical clerkship and you're given the opportunity to suture an incision, it's very important to have no tension on that incision because that can impair healing. Other mechanical factors such as pressure and torsion can also have an impact. Foreign bodies such as sutures, or this is why we remove our sutures after, let's say you've had this surgery at 10 days or 7 days, we'll remove that suture. That's because if you leave it there, you're going to get chronic inflammation. The granulomatous inflammation that we discussed in the patterns of acute inflammation is going to keep that slow burn going and impede healing. Poor perfusion of any type, whether it's just due to peripheral vascular disease, as we see in diabetes, atherosclerosis, we can get obstructed venous drainage in the case of varicose veins. That's going to decrease oxygenation as well as impede leukocyte migration. The type and extent of injury are important because if you have tissue architectural destruction, as I've already mentioned, that's going to drive us more towards scarring. And we also have to be aware of, does this cell have the ability to regenerate? Because that's going to be a factor, for example, in cardiac myocyte damage. And then finally, the location of injury. So in the patterns of inflammation, I talk about fibrinous inflammation in the pericardial sac, so fibrinous pericarditis. If you have a large exudate of protein, the body has to clear that, and part of its attempt to clear that might involve scarring, and this can lead to a constrictive pericarditis. As always, I'm going to finish with a few questions. You can go ahead and pause, reflect on what you've learned, and if necessary, watch the video again. As always, thank you very much for your time. Follow me on Twitter. Comments down below are always appreciated. Thank you very much.